Christopher. The floor is yours.
Great, thank you, John. Could you see the screen okay? It's just
yeah, it looks good.
Just thank you. Great. Okay, thank you, John, and thank you, Attorney Manalestas and Alex, for your introductions as well. I'm really pleased today to be able to share with you a few of the findings that experiences from Public Health England that we've had throughout the pandemic in relation to training staff. As John mentioned earlier, the Sport Package 7 is very much about surge capacity and pandemics. And this webinar really is about the capacity to well, when there is a surge capacity, one area that we might have to think about is making sure that we have enough staff trained to deal with that capacity and trained in the techniques that might evolve during a pandemic. So I hope to touch on that today. To give you a brief introduction about myself, my name is Christopher Logue. I'm the virology lead at Public Health England's Novel and Dangerous Pathogens training team. And we're an Applied Biosafety and Training WHO Collaborating Centre. We've worked very closely with colleagues in the EU before and in a broad range of countries, and so delighted to be working again in Southeast Asia and with UniCRE and the CBRN Centres of Excellence. So a brief overview of today's presentation. Really, it's to give you an idea of the normal activities, I think, to put in context this kind of normal activities that we do here at BHE, and then to look at how that shifted during the pandemic to respond to the new activities and demands that the pandemic produced. Obviously, there were many challenges across a whole array of areas as we all around the world have faced. So I'll just touch on a couple of those that were relevant to today's presentation. And then start to go into the sort of the training requirements, the training structures. So our team here is responsible for training all of the Public Health England laboratory staff in working safely with dangerous pathogens. So we'll talk a little bit about that. And then I really just want to spend the rest of the time just giving you, presenting you the e-learning that we've developed for you to be able to avail of for your institutions through Project AT1. There's a lot of material, so rather than have you sit through 5 hours of the actual e-learning, what I've done is I sort of summarized it into overview of each slide. Okay, so that's what we're planning. As John said, please just put any questions into the chat box or question and answers box if you have them as we go along, and then we can address them later. Okay, so Public Health England, to start with, is an executive agency within the UK Department of Health and Social Care. We're the government public health agency. We're split across different sites, but I'm based at Porton Down, and in our site, the focus is very much on the infectious disease. Other sites deal with more health-related issues such as diabetes, childhood obesity, things like that. The site of Porton is very much more specific to high containment and research and work around high containment and emergency responses. We also have an animal wing, a BSL-3, and several BSL-3 labs, a BSL-4 lab. So we carry out a lot of work and validation of vaccines and drugs and a wide range of studies looking at infectious pathogens. And part of that, where we fit in, is we have our laboratory for training staff here and then with colleagues overseas. So this is what we would normally do on a normal week. Activities throughout these areas would be normal. Moving forward to the responses in COVID, and this is probably the busiest slide I have, but we had to make a lot of shifts and move to new areas that we perhaps didn't have the same level of day-to-day experience in, but we had the facilities, the staff, and as the Public Health Institute for the nation, it fell on us to do a lot of this work. So, for example, the very first one, we supported in vivo studies for some of the vaccines that are now being used around the world. The early studies for those, we evaluated hundreds. We had teams evaluate hundreds of different commercial diagnostic lateral flow device kits to shortlist a very, very short list of kits that we felt were specific enough and to a standard that we could actually use in the public. We had the high throughput PCR PCR capacity, and as a lot of different advances were made, such as sequencing pathogens and monitoring the variants, we were able to and are continually able to support that as well. So a lot of new activities, but activities nonetheless that we were able to carry out at a large scale. So some of those challenges that we met, obviously, were as case numbers started rising, of course, so too did the need for more and more testing. And even though we had the government and scientists had predictive models, this was a continually shifting environment where numbers would change quite dramatically. Like a lot of you, I imagine, in your labs, getting hold of the reagents and the consumables and the appropriate equipment proved quite difficult, and we in fact had to start looking at creating in some cases creating our own reagents using core ingredients, which also became in short supply. So that was a challenge. Staff, the staff that would normally be on site, some of them were actually COVID positive, some of them were contacts of individuals who tested positive for SARS-CoV-2. And then with the schools and nurseries, in many cases, these were closed initially. Obviously, their parents of those children couldn't come to work to work here. So there were lots of challenges. We soon realized that we would need a lot of new staff. So recruiting staff rapidly is never easy, even outside of pandemic times. And any new staff that we did have, and existing staff, we really needed to be able to train them to be able to deal with these new demands. So when it came to training in a pandemic versus training normally, normally you have new recruits coming in smaller numbers, whereas when you rapidly need larger numbers of staff, you will also have larger numbers of recruits coming in at the same time. So we had a combination here of existing staff who might have been experienced in working in one field, who were then, that business as usual was reduced so that they could focus on working COVID. So while we had existing staff who were familiar with many of the lab, the assays themselves were challenging potentially. Obviously, we had the ability to do some remote learning, which is what I'm going to talk about today, the e-learning, which is really great to have that capability, but again, it still would require some hands-on follow-up. Lab training, we could do that, but obviously with an increased COVID risk of people who weren't potentially asymptomatic infecting others, so requiring additional social distancing, which brought with it limitations to how many people you could train in one go. And then I was going to say,
we should have a poll fairly soon, shouldn't we?
Yeah, just at the end of this slide, we'll have our.
Yeah, okay. I'll get things warmed up.
Yeah. So, and with the assays changing, with the way we were actually testing for the virus changing, obviously the requirement for new protocols and updating protocols and the risk assessments associated with them was continually ongoing and had to be addressed as well. So a few things we had to take in mind for training. So I think John's going to now put up a couple of poll questions.
Yep, I will do that. Bear with me. So the first question is about your institution. Let me launch it. So here we go. Hopefully that will come up. So did your institution's response to the pandemic involve laboratory activities, e.g. testing for SARS-CoV-2? So yes, no, and so on. I normally ask Christopher or the panelists to guess what's going to come out tops on this. I think this is too easy. So I won't What do you reckon, Christopher? Do you think it's more yeses than nos, or?
I think, I mean, it depends who the makeup of the audience is, of course, but generally, I mean, what people do overlook sometimes is the fact that just because an institution wasn't directly involved in the testing, it doesn't mean they didn't support in many other ways. So, for example, many care homes and hospitals would have been responding to the pandemic on the front line, however, wouldn't have had any direct lab activity that might have been sent elsewhere. Indeed.
Yes, it's true. But anyway, I mean, it's coming in. You'll be pleased to know that the majority have been involved in some way directly. So I'll just give it another few seconds. Yeah, the vast majority actually. So I think
that's good, because it means the rest of the slides hopefully will be some more relevant.
Yeah, no, that's perfect. Yeah, we've got 65, 70% of the audience having answered now. So I won't delay things any longer. I'll just end it and then results. Yeah.
You had another poll as well.
Okay. I have another one to launch in a minute. Yeah.
So yeah, the 13% of institutions that weren't directly lab active, by no means does that mean that they weren't active in the response.
No. And also they may be in a position where actually understanding what's required, in training for training of staff might be of interest to them as well. So let me stop sharing that one, and then I'll launch the next poll, which is the lab response poll. This is self-explanatory. It goes up now. So there are parts of your institution's laboratory response to the pandemic. Did you work with reduced staff numbers? So staff were absent, so you didn't have enough to go around. Were you able to maintain your existing level, similar staff numbers? Did you have to recruit or second more staff, pull them in from elsewhere? Or is it, you had no lab response, no direct laboratory response in the SARS-CoV-2 epidemic?
So for this one, I imagine we would.
Oh, you're going to offer it. You're going to offer it.
Yeah, before you can grill me. Yeah, I would imagine that most people had to work with reduced staff numbers because of the very natures of each country's lockdown. Initially, it took a while for exceptions for frontline workers, for example, to be implemented to allow people to go to work. And like I said earlier, childcare was a big factor in how people and if people go to work.
I think this is going to be skewed slightly because it's a single choice.
I mean, 1 and 3 are interlinked.
Yeah, absolutely. So I think that's where they're going to go. Still a few answers coming in. I mean, I guess it will go in phases. I would imagine that at the beginning you'd have to work with reduced staff numbers because of all the problems that you've just mentioned, as people have to drift away because of social distancing, healthcare, and everything else that's going on. And then you stabilize. Then you have to recruit more staff, and that takes its own time. So I guess all 3 of those will appear in peaks at some point. Okay, look, we're nearly there. We've got getting close. I'll just give you another 5 seconds, run it to 2 minutes, and okay, I'm going to end the poll now. We got not everybody's answered, but that's okay. Out of those that answered, 61% answered. Okay. So yeah, there's a balance. So obviously quite a pressure on recruiting or seconding more staff. And I guess the implication of that is more training. So hopefully this will give some insights, and we can move on. Okay, I'll stop sharing now. We've got a few more polls coming up a little bit later on in the presentation. Okay, back to you, Christopher. Thank you.
Okay, so yeah, with regard to the training, we kind of could look at it in this sort of structure, and we had to look at it in a way of trying to get information across to new starters and existing staff, balancing that with the ongoing, evolving documentation that was being produced and the situation. So really the top half, and then the bottom half was how we could follow that up with some lab-based training and on-the-job mentoring. So we had a blended approach of all of these. Fortunately, with e-learning, we were people could work on this remotely. This meant that we could provide information for people who didn't necessarily have to be on site, didn't have to be in the lab. And we could really try to provide an initial experience in what the procedures were going to be, how they would be carried out. We had demonstrations, we could demonstrate through videos, through various media formats, a lot of the ground protocols and principles that would be required of them when they moved into a lab. In addition to this, and that could be continually assessed, in addition to this, they were also able to be sent the latest SOPs and the laboratory codes of practice and the risk assessments to familiarize themselves with those and the equipment as well. So once that first sort of half of this had been conducted, we could then start bringing people in smaller groups to train them in our training lab, to reinforce what they'd learned on the e-learning. And then finally, once they moved into the actual, once they've been assessed on that, then they could move into the lab to just receive the actual on-the-job training. So it was a sort of structured approach, but today is really focusing on what we can deliver on the e-learning, because the more we could use that, the less time we really had to spend, especially on the lab-based training, because the e-learning was quite engaging. That would actually demonstrate quite a lot of the techniques. So that familiarization was already present by the time they came to the lab. So while a blended approach, today I'm just going to focus on the e-learning.
Christopher, I wonder,
yep.
before we have a couple of polls there. One was on the who was being trained, and the second one was on the type of training that's been received. Should I launch that now quickly before we continue?
Yeah, I was going to say at the end of this slide, but
okay.
Let's do
the first one, and then at the end of this slide, I'll do the second one. So the first one is simply about did you have to train people, basically. So there you go. So did you have to train existing staff, new staff, combination of existing and new staff, or no additional training? So how did that work out in your institution? I'll give us a feel of how it went. I suspect it's going to be, well, my turn to guess. Well, I can see what's going on, so I can cheat, but it's going to be a combination. Yeah.
I think from the previous poll that was clear as well. Sure. I mean, we may as well do the next poll question after this immediately, and then jump into the training.
So what you're trying to say is I'm not quite so sharp as I thought I was.
No.
Okay. Let's have a look. Yeah, you're right. It's cranking up to a combination of.
And I think that's actually really important, because you have to, and where e-learning hopefully will come into this, is you have to ensure that whoever you are training, whether they're existing staff or new staff, that they're all competent to the same level going in. And sometimes having existing staff who've been doing a particular job for several years, during that time as well, they're picking up a lot of experience, but there's also the potential for bad habits to be picked up along the way as well. Yeah. Whereas somebody straight out of university, for example, mightn't have had very much laboratory experience, but may be more open to essentially following step-by-step instructions. So it's a combination of learning styles as well that we had to address in the e-learning, and we think we've achieved this, and hope we've achieved this.
I think we've peaked out on answers, so I'll end the poll and share the results with you. Yeah, as you say, no surprises there. It was a combination. Very few said that no additional training was required. So, I mean, interesting that there are some people that felt that additional wasn't required. Okay, I'll move on to the next one quickly.
Yeah. I think that no additional might be to do with not having been directly involved from a laboratory point.
Yeah. That's true. Okay, so the next one is about training format, and then I promise we'll leave you alone on the polls until much later in the presentation. So here's the next one. During the pandemic, which format or what format was or is the training provided to your staff? Is it face-to-face, lab, in the lab, classroom, office? Was it remotely, webinars, web-based e-learning? A blended combination of all of it? Or was it on the job, hands-on, being guided by individuals, mentoring, and so on.
And I think this question for me anyway, it's one of the more important ones because it really, it might show us how we've had to change the way we deliver training because of the circumstances. Previously, we might have delivered training in a specific way, perhaps in the lab or classroom, but because of the nature of social distancing and the pandemic, we might have been, our colleagues might have been forced to change that way.
Yeah, I mean, I think, I mean, e-learning in the past has been seen as a way of reducing costs as much as anything else, and you know, and widen availability of stuff, I guess, also. But the pandemic has shifted that quite a lot, simply because we can't do the face-to-face stuff in the way that we did before. Mm-hmm. So it's pushed it. It'll be interesting to see whether this will stay like this. If we were to do this poll in, say, 2 years' time, whether the emphasis on remote would be as high as it is now, or blended will be as high as it is now. Yeah.
Or had we done this 2 years ago, what would the
we've done a baseline a couple of years ago. I bet this would be slightly different. Okay, look, yeah, we've ended 1 minute and a half, minute and 3/4. Okay, let's. I think it's topped out. Let's see what we've got, and I'll share the results. There you go.
Great.
Yeah, so blended. So interesting that, you know, there's still some face-to-face going on, which is great. Some remote, obviously, or a higher proportion of remote, and then blended, which I think is the obvious answer. And then also some on-the-job stuff. So that's also important, mentoring and practical training.
Right.
Yeah. Okay.
Yeah.
All right.
Okay. Well, I mean, blended matches what we'll be talking about today, because it really was. While I'll be talking about e-learning, it was e-learning as part of the blended approach. So we can.
Okay. I'll close that and go back to the slides. Sorry. Yeah.
So yeah, with the e-learning, the other thing was where we the training team were a finite size. So while we could train people using the e-learning, that actually freed up our time to then actually follow that e-learning training up with the required lab training that needed to follow on from it. So it was very useful for us in that respect. It also gave an overview to the individuals and the context and a background of what was happening, which sometimes during a pandemic can be quite difficult to actually know where you fit in and know how the piece of work or the role that you're involved in doing, how that fits into the bigger picture. Like I said before, we had this level of competency that we could assess, which ensured that all trainers had been trained to the same level. And with e-learning on a learning management system, you have an ability to see how did somebody do all of the stages, or did they just press next the whole way to the end and do the assessment. E-learning is very useful because it lets you see that sort of information, so you can build up a picture of someone's learning. Easily and rapidly updatable. As I said previously, we had a situation where things were changing very fast. Case numbers were changing very fast. The type of assays we were using, the assays that replaced the previous assays, all of these things played a large role. But the benefit is that a user could work remotely at their own pace, at home, doing this in the evening or whenever they were able to. And it reduced any person-to-person physical interaction at the beginning of the outbreak when people were uncertain. So while this was developed for our own staff, it's now very much what I'll show you today has been adapted for Project 81 partner countries. So for the institutions that hopefully in the audience today you're interested in seeing this for you. So without further ado, I will actually move straight to the overview of the course itself. So on signing up, you would get your own. It's frozen, sorry. Apologies, my computer is just there. We go. Once you had your registered, you would get your own login details. These are private to you, and then you'd be sent the URL to the website for you to be able to just to log in. And then this would be the welcome page you'd see. This would be the actual course at the beginning of the course. On clicking at the bottom, there's you can move between pages, and in the background you have availability at all time as a sort of library of resources. So all of the documentation that you need, all of these SOPs I mentioned, all of the new guidances, all of this, we would continually upload these resources. So you had one place to check, which made things quite simple. And it meant also that we could refer people to things. Also, you had a glossary for terms you might have been unfamiliar with and a menu to navigate if needed. Then an individual would just type in their name, and at the very end, they would get a certificate of completion, which was the evidence competence base that they had completed the training. And this was a score with a pass mark for each section and compiled to give you an overall certificate of completion. And that was part of your training record to be able to move into the lab follow-up. The modules that we offered in this e-learning there were 8 modules, but really 6 technical modules. So an introduction, a background to the virus, followed by quality and the need for it, sample reception. Sample reception and sample processing were very much hands-on video demos. We'll look at some of those in a minute. Through to the sort of subtleties of molecular diagnostics and the results and reporting, how you interpret a result, and what the mechanism here in the UK anyway is in place to report those. And then modules 7 and 8, one was a summary. And while there were questions throughout these different modules, there was also an assessment module at the end with additional questions. So if we started off by clicking introduction, this would be our first workflow. So I'm going to go through each of the modules quite fast. So this isn't really everyone sitting together to do the e-learning. It's just to get a flavor for it, to see if you're interested in signing up to do it. So the module 1 was really about an introduction to SARS-CoV-2 and COVID-19. As we learned more, we could update this. And it had a sort of format where the presenter would be able, we could have a voiceover for this. We had voiceover of this so that it could be more engaging as well. So initially it would be a brief overview, and then every time you saw this virus appear, that's what you would click to learn more. So to follow through with these, we had a brief overview, but we also had what were the symptoms, the recovery rate, who was most affected, the coronavirus itself, and more detail behind the scenes here about the structure of it, the reservoirs, what animal reservoirs there were, chain of infection as it was understood at the time, the mutations as they suddenly started emerging during the pandemic, what variants of concern were, and then a summary towards the end of that. So by clicking each of these various links or these triggers, it would bring you out of that screen and into its own sort of larger screen here. So for example, this was on the 29th of April when this training was given, and this is what we saw. Now, as this morning, I went to the same coronavirus dashboard. So there was 149 million cases in April, and then just this morning I saw there were 232 million cases with 4.7 billion deaths. But 5.9 billion vaccine doses have been administered. So this information could be updated for each on a regular basis. Other kind of information we were providing would have included a background on what viruses were human viruses, human coronaviruses, so MERS and SARS-CoV-1. Then I mentioned the host species earlier. So each of these screens here would have come up in more detail on triggering in the previous slides. And then later on, as we started moving through the pandemic and the WHO introduced the nomenclature, we were able to then include the alpha, beta, gamma, and delta definitions and what that meant. So throughout, as I mentioned, throughout the e-learning, we have engaging and interactive questions. So in this one, they would drag the particular biohazard ball to its appropriate name badge. So coronavirus disease 2019, that was obviously COVID-19 would get dragged up there. And as we moved along, we would fill these out, and that would already be the first correct answer. If they got that right, that would go on to that was part of their assessment score. This is starting to build already in module 1. If they got it wrong, they were allowed to go back and try several times throughout the thing. So that was really the background covered, and then we wanted to give an overview of the laboratory handling and expand on the terminology. So we had laboratory discipline, point of care, molecular diagnostics, cell culture. So depending on what the task might have been involved for those individuals, we wanted to ensure that the basic principles of avoiding lab-acquired infections was made clear. So laboratory discipline had obviously good microbiology practices, point of care testing defined, molecular diagnostic defined, and that's really what we focused on here. And then culturing viruses and talking about how how culturing would require different containment levels, perhaps, or higher, initially. So differentiating between the different types of work was key. That allowed us then to introduce this kind of diagnostic workflow that we were looking at. So so each of these 8 components of the workflow, we would go into in much more detail. So if we just look at the first 4, we had sample collection, the types of samples they were receiving, sample delivery, how it needed to be delivered, who could deliver it, sample reception. We have an entire section later on sample reception, but again, just the basics to set the setting, and sample processing, an overview of the overall process. Now, if we look at the next 4, molecular diagnostics, what type of PCR was being done, how results were validated, the need to report the results to clinicians so that they could be, so that the patient could then be notified. So again, a background about the biosafety and about the safe workings and an overview of the workflow as it was intended. We would throw in another question. So in this case, we defined what a hazard is and a risk is. So what would be the principal laboratory hazard when handling a patient sample? So in this case, they would choose one of these and drag it into the square here. So spoiler alert, it's biological aerosol. And then again, that's another question. Now, if they got that right, it goes to their points, and if not, they can try again. Oh, sorry, John, I didn't realize that we're going to do the poll. Apologies. So I think I've given the answer away. So okay, I can't hear anything. Are we waiting for this answer to come back, or am I pressing on? Okay, no audio. So, sorry, John, you're on mute. I'm not sure if.
Sorry, when I looked at this initially, I saw one of these as a distraction. I think there's some validity in all of them in some ways, of course, but of course the answer that you're looking for is a particular one. Okay, look, yeah. I'm going to end the poll now.
Yeah, great. Sorry,
you can see what's there. You go. So that's what we got. And
hopefully
yeah.
Okay. Fab.
Yeah,
hopefully
but interesting.
That was before.
yeah. Interesting. People have picked up sharps, which I thought as well about sharps. But I mean, this is the definition of the question is the main risk, is it?
Yeah.
Yeah.
Principal risk.
Principal risk. Yeah. Exactly. Okay. But so that gives a flavor of how the thing works. And if I get this right, Christopher, you would need to answer that correctly before you could move on to the next one. Is that how it works?
Yeah, you would be given a certain number of tries. So I think 3 tries for this question. Right, I'm struggling to get my mouse back onto the page.
And you'd be pleased to know that that's the last poll.
Yeah. Sorry, I can't. I'm on the wrong page here. Let's try this again. I'm just going to try to reconnect because it froze on me there.
Okay. It's always the way, isn't it? Okay. When I started out this morning, Mr. McIntosh decided that he was going to upgrade the system software, and so I was nearly late for the webinar as a result.
Okay, so
I guess one of those things. There you go. You're back. Yeah.
You can see that.
Yeah, you're not in presenter view yet, but if you click on the little icon at the bottom to put it into presentation mode, or F5 or whatever it is.
Sorry, where did that go?
While you're talking, we're getting a couple of questions about the link for the e-learning. I bet I should repeat that again, that at the end of the webinar, you'll automatically receive a feedback questionnaire. If you say on that feedback questionnaire you're interested in participating in the e-learning module, we will send you the link. I just had one question now on that, but the process would be fill in the questionnaire. We'll send it on to Public Health England, and they'll create an account for you so that you can access the e-learning module. And then subsequently, for those that didn't attend, I will put the link on the website. But those of you that have attended today will automatically get priority access to the e-learning module. So anyway, thanks, Christopher.
Okay, so can you see the screen now?
Yep.
Okay, great. So that was really the end of module 1. Then module 2 went into quality control, and every module had its aims laid out at the beginning. And here we were really looking at the importance of quality and looking at the pre-analytical, the analytical, and the post-analytical phases of testing. So individuals would click on the pre-analytical, and there was a series of engaged presentations here where every time someone would click on an information bubble, we get more facts, and then anytime someone would click on the image, they would get a full screen image, allowing them to really look into the detail of what was being shown. Likewise, for the analytical phase, here's an example of what one of these little information bubbles could do. So all of this information was then just gone through gradually. Post-analytical, if we were to zoom in on the actual paperwork, the reports themselves would highlight what needed to be included for results to be accepted. With quality, we have the process controls, the 4 process controls, so procedure, control, indicator, training, and audit, and each of these had their own section then as well. And again, another question, another assessment, drop-down lists of definitions, and this would allow us to see what was picked up earlier, because all of these definitions have been used in the earlier content. So there'll be a drop-down list, and selecting the appropriate ones will result in an appropriate, the right answer and a score. Again, behind the scenes score that's building up this individual's competency profile, which is the key thing. Module 3, sample reception, and in this one we really focus much more on video and demonstrations. We start with a familiarization of the principles, so what the actual requirements are, the storage requirements, but the UN labeling, defining what each of the receptacles might look like, and we were able to get images of everything in the UK. So, for example, if we're doing this for Philippines, Malaysia, you could provide images and photos of your own specific receptacles, as we have here in the UK, or for any other country for that matter. And then just going through the various packaging step by step, and defining what could be done on the bench, and then what we would need to do in our biosafety cabinets. And we divided it into to which section gets done where. But as I said earlier, most importantly, really here was the integrity of the samples. And this was really demonstrated by really close-up pictures of real examples that people might face using real props. So these are the same tubes that would have come in from the hospitals in the same bags. And then we were able to doctor these to have some that were leaking, some that were mislabeled, some that had too little information, etc. And when it came to the actual procedure through each stage, we were then able to produce several short videos which would work through the process. For example, down here we have a leaky sample. So this is the sample then we brought into a class 1 and dealt with there immediately. And then we have a video about how we would deal with a leaky sample, or how we deal with samples that we're unsure of. And these videos would all be short, between 1 to 3 minutes long. This will be followed on by our own SOPs. So we're introducing now the SOPs for our laboratory. So again, if this was to be tailored for your institution, you might want to provide the specific details that would allow that to be implemented. And likewise, again, we had a particular way of processing samples. So these samples were processed according to our SOPs. So this would be different for different labs, but the principles, again, are the same. This would be another question. So we've got 5 different samples based off what you would have learned in the earlier questions. Any of these that have integrity issues, we would drag that sample into this area here, leaving only the sample that we're going to process. And if you click any of these, you then get the zoomed in pictures. So this one's leaking, for example. This one, it's the wrong kind of swab. This one looks good to start with, but there's actually no swab in here at all. This one is the only one I think that actually has everything included as it should do, and this one's empty. So they would really have to look at these in quite detail and really try to work out if the paperwork matched, if all of these variables were appropriate. That was the end of sample reception. And then we would move into the various procedures for sample processing. And here we were instilling good practices where possible, and highlighting methodologies to reduce any potential contamination. Again, should you click any of these details, you get more detail about each component here. So the individuals were certain that they were dealing with the appropriate information. And again, more questions where they would have multiple choices and they would have to select the appropriate ones. So again, this continuous assessment throughout the process. So even the most exam test phobic people, where it didn't have that feel. And that's pretty much it for module 4, because so much of module 4 was hands-on. This is sample processing, was hands-on material. We could show them how to do it, and we had several videos going through each step of the process, voiced over with step-by-step instructions, so that when they did come into the lab later on, they would already be familiar with the setup, the structure, and the protocol. But by no means does this replace, at this point, the requirement for lab training. It just shortens the length of time that lab training might take, and it gives a familiarity with the content in advance of lab training, allowing for that lab training to be much more effective. Module 5, again, this is the molecular components of it. So we didn't delve too much. We gave backgrounds into the processes. So the fact that coronaviruses are RNA viruses, how we form cDNA, the PCR, the background of PCR, real-time PCR, and then the definitions of some of the key factors key terminologies that they would be familiar with in the lab. This would also include how to prevent contamination. And you might think this is repetition, where we've got reducing cross-contamination and best practices, but it is quite different, because in the earlier session with the module 4, we're looking at preventing contamination and infection and any kind of where we were working with infectious material. which is different from working with molecular material, and they both have their own sets of challenges, and we address those head on. And again, more tests throughout the process, more questions, more assessments. So obviously, while wearing 3 pairs of gloves might reduce the fact that your chances of your skin becoming in contact with anything, at the same time, it's going to also reduce your dexterity and thereby increase your likelihood to have something knock over still in the first place. Earphones are a great way to block out background noise, but they're not great if you need to actually listen to alarms and other things in the laboratory that are key. But the other components obviously all have their place in improving quality and consistency and safety. And then finally, the final module here is the results and reporting. So because we previously discussed PCR and the processes involved, and they're familiar with the terminology, now we could throw at the individuals actual data. So here again is this is what it looks like. This is the target region, giving them a few examples of how these could look on different platforms. And then moving on to concepts like threshold and controls, how particular commercial kits that were being used, how they presented their work and their results, and then finally how the terminology used in reports was key. For example, with a positive case, you would say RNA was detected. You might not, and the comment indicates the patient is positive, but it's an indication, it's not definitive. So, and here again, this is where we got into much more detailed questions and answers. We will present data where we've got a series of various results, and they had to decide, would they accept this? Was the run valid? Was this something that we would they would be able to this is a result they could release. So in this case, we've got the non-template control, which should be negative, below the threshold, as you know. Then we have a negative extraction, which is a sample that we do at the same time as a patient sample in order to ensure that we're monitoring for any cross-contamination. So that should be negative. And then we have our positive control. This one is quite strong. It probably wouldn't need to be that strong. And then our patient samples. So we can select the right answers. So was the template detected? No, that's good. Was the positive control detected? Yes, that's good. Is the run valid? Yep, the controls all works. Does the patient 1 have RNA detected? Patient 1, no. So that patient would be considered negative. Here we have a more complex one, but in this case, our negative extraction control has actually come up positive. So that shouldn't happen. That means there's been cross-contamination at some point during the extraction process. So then the samples should be retested. All of these samples should be retested because of this. So having covered some of this material earlier, they give this familiarity is dealing with the data is much easier. And then to follow up, then we would have the summary of the entire process, but for brevity today, we won't cover that. So that's really of what the e-learning was and how we developed it. And it had a few outcomes. It allowed us to train a lot of individuals before they even come on site, which was key. This also allowed the staff that we did have on site for training to be able to follow up with smaller groups of individuals as and when they finished the remote training. They could come in for a day or 2 days at different times to actually do the training prior to working in the lab. And this was a continual process. So that's something we were focused on. It also, it reduced the time for the training, which meant that given that we were socially distancing within the laboratories, we could have less people in. So less people being trained at one time, combined with reduced time, meant that we weren't losing out. We had staff competency records based off all of this, and that was really useful because it helped us identify where strengths for the individuals lay. And as there were 2 distinct processes, the actual molecular diagnostic side of this, but also the sample reception side, 2 separate labs doing 2 separate things that combine to give the full picture, we identified individuals who were much more prone to, or better, their assessment showed that they were more suited for sample reception, that looking at attention to detail in the text and matching up things, versus molecular diagnostics, where those individuals might have a troubleshooting expertise that was useful. So it was very useful that way. And then, as I said earlier, we could update this routinely. And as a model, as a structure, it can be adapted for other. We take out the molecular module and put in the serology module. A lot of the biosafety elements can be, and sample reception elements wouldn't necessarily change. So really, this is coming to the end now, the last slide or two. Where we see this and where we hope Project 81 and all of you who are interested, we could see this being a mechanism for you and for any other labs around the world, including in our own institutions. This can be tailored for the end user's local environment. So instead of having pictures of PPE and individuals that work in our labs, we swap those out for individuals and PPE from your lab and consumables from your labs. The videos could, by seeing the videos that we've provided, you could easily record those videos yourselves in your environment to match your SOPs. Every slide has a voiceover, an option for a voiceover. Sometimes we don't always include voiceovers because it can detract from the message. But where a voiceover is there and where text is there, this can be translated. Other modules can be added. For example, the actual first step of swabbing an individual could be part of this. It can be switched between pathogens. We swap out SARS, CoE2 and put in Nipah, for example, and change the content and have a Nipah module that fits in. But Nipah is probably not the best example because it's a hazard group 4 pathogen, but for other hazard group 3 pathogens, there's no need to buy software. It's hosted by Public Health England, so there's no cost. And because it's virtual, there's no limited number of users to actually do it. So I think John will follow up on this. So if you are interested in participating, then John will provide you with a feedback form today, which he'll forward to us, and then we can give you your own login and you can start accessing the material as soon as you want. I'm not sure about the email address at the bottom. I'll just let John, I'll let you decide that. But finally, just an acknowledgement. I mean, putting this stuff together, we've got our team here on site. My colleague Colette was involved in a lot of the clinical side of this, and then all of the consortium members were working together as one big team to try to bring in our areas of expertise from our different institutes to populate this kind of learning. And then yes, thank you to Mr. Manastis, Sabai, who's always there at the end of the phone and publicizes all of our activities, which is phenomenal. Yes, and Alex, good to have you back in the region. And thank you, DevGo, for funding this. And that's it. Thank you very much.
Okay, Christopher, thank you very much. That's excellent. We've got a couple of questions coming in, actually, and one which came up yesterday when we were discussing the module, and that is how long. So it came in from Tibashini near Satasivan, and saying, is there any time limit to complete the module? So, I mean, I think probably how long does it take to complete the module, or what would you recommend? And then, is there a time limit? Can you come in and go out and come back again, and that kind of thing?
Yeah. So, I mean, the module takes between 4 to 5 hours. So, the e-learning. So each module could take about an hour, a little less. But that's if you do it all in one go. I mean, the idea about this is there's no penalties for dipping in and out and completing it in different stages. The idea is that it's accessible for you regardless of your own settings. So being able to being able to do it, you could do it over 5 days, one evening a week. It really was completely up to the individuals. We normally started to arrange follow-up training within a week of the e-learning because we didn't want all of the e-learning content to start being lost prior to coming into the lab for short trainings.
So at the moment, if delegates here create an account with you and they access the modules, they'll see the module as you've described it. So if we're talking about customization, that could happen later. But at the moment, it's as you've described it today.
Yeah. So, I mean, and the ideal, I mean, what we'd like you guys to do is to, if you want to make this more bespoke for your own countries, to just supply us with the relevant material, because one thing about training and learning and retention is the more it reflects what you do yourselves, the higher the retention, and people really follow that a lot better than just looking at someone else's lab.
Sure, good. I've probably another couple of questions in my mind, but I wanted to ask Sabai if she's with us, if she could join us, about your views on how this module might fit with existing training in the region. I mean, you can concentrate on Singapore if you like, but I mean, other countries in the region as well. I mean, I would imagine from the answers to the questions we received earlier that people are already accessing e-learning modules in some way, and therefore, how would you see this module, Christopher's module, and the others, how they would fit into the existing set of e-learning modules that are available in Southeast Asia at the moment?
Because I'm not in the laboratory now, so I'm not following up the trend, the training in the region, how the e-learning training, I mean, which organization is doing, but I believe the WHO has the e-learning process. So people usually tap into the WHO website, but the different e-learnings have different objectives. I think that the Public Health England e-learning is a much more focused on the laboratory hands-on approach. So I bet the people, like Christopher said, if people can study with their own pace first before coming into the lab, that is really useful. For me, that model is quite nicely fitting into the current situation in Southeast Asia region, because many COVID cases rising up, and then so it is very difficult to train the new person in the large group. So we have the trainers have to arrange 1 to 2 people only, because of the you cannot train more than 2 or 3 people nowadays. So if they can study first through the e-learning and then come to the lab, it would be easier, I think, for both sides, the trainer as well as the trainees.
Yeah, okay. Thanks, Sabai. That's really interesting. I had a hand up earlier from VG, but I think she's just gone. I was going to ask her if she wanted to ask a question, but I think VG has just left the seminar. Maybe she was putting her hand up to say that she was having to go, which is a shame.
Oh,
okay.
She's still there. I see her hands.
Yeah, I think I can't. If she's still there and she has a question, maybe she could type it in. But according to the participants list, she's dropped out now. So maybe she's had a connection problem. Well, VG, if you're there, please type in a question. I can allow you to talk if you want to, but I think you may have gone. Okay. Well, if there's any other questions, please fire them in. The last thing I wanted to do was just explain to you a little bit about the feedback form and the registration process. So I'm just going to share my screen really quickly. Let's get the right one. There we go. Let's share this. So this is the feedback form that you will receive. It'll come automatically at the end of the webinar for those that logged in today. So basically, the standard question: name, email, which country you're coming from, the name of your institution. Oh, Vij is back. Okay, I'll come to you in a minute, Vij. The satisfaction of the event, how you choose the content. Now, if you answer on this one, yes, definitely, you plan to access the e-learning module, I'll record that and I'll send your details on to Public Health England, and they will generate an account to you and email you about how to access it. So that will provide you with a login. Eventually, I mean, after the webinar, I will in fact make it more widely available. But those of you that attended today, we can allow you to get early access to that. VG's back. Hang on, let's see what she wants to say. Where's VG? VG, I can put you on if you want to speak. If you're there, might be easier than trying to type all this stuff. How are you doing anyway? Good to hear from you.
Hi everybody. I'm fine. Can you guys hear me?
Yeah, perfectly.
Yeah. Okay. So I'm not so involved in this project, but I've been doing quite a lot of work in the region. And just like what Sabai pointed out, what most of them seem to do is buy the kits. Unless they are from a more developed country, then they are able to make their own primers and things. But several countries do buy the kits, which are supplied to them at subsidized rates, I'm told. And then what they would do is they would read the inserts in the kit, and then they would follow the WHO guideline, because one of the things they constantly ask me is it necessary to use a biosafety cabinet for all of them? Now, if you look at the CDC WHO guidelines, if you use the kit, they do say that if you follow good microbiological practice, you can do away without, you can do without a BSC, because some places just don't have. So I also know that there is some kind of a little bit of tension between those who say you must use a biosafety cabinet, but then there is no biosafety cabinet. So what do? This kind of tension has been arising, and they do their best. I think if they buy the kits and they follow the WHO CDC guidelines, and if they are very strongly encouraged to use a biosafety cabinet, but if they are unable to, then they would just work on the bench following the CDC WHO guidelines. Of course, the other problem is the biosafety cabinet really working as a biosafety cabinet, because oftentimes it's not certified in these regions. That's all I had to say. Thank you very much for unmuting me.
Great to hear from you, VG. Hopefully we'll be able to do some work once we start traveling. It'd be good to catch up with you anyway.
I'm looking forward to that.
So I think just to address the question, just briefly, in the short, I mean, the WHO, the fourth edition of the WHO laboratory manual is actually very good in that it tackles risk assessment in a new way that says, okay, you don't necessarily need a specific containment level laboratory to deal with a specific hazard group pathogen. What you do need is to have effective control measures in place. So where people didn't have a biosafety cabinet, there are other control measures that can be put in place to reduce the risk of any lab-acquired infections. Of course, biosafety cabinets are preferable, but for all of the downstream steps, once the sample's inactivated, obviously there's no real, the reason for biosafety cabinet is more about quality for the sample rather than safety for the individual working on it. So if there's mechanisms in place to inactivate the sample safely, then all of the downstream steps could be handled in a less contained environment. But I guess the idea of this training is to provide all users with the principles and knowledge and confidence in making those decisions, in understanding why something might need to be handled in a specific way, and how we can reduce cross-contamination, how we can reduce the risks of getting contaminated. So we deliberately don't focus on specific kits on this training. We talk about the overall role of all kits and what they do. And of course, some kits are better than others. So it really comes down to what's available. But the idea here is the principles are clear, and it's making it a safer environment, and an environment where people can ask questions without feeling that they're going to be criticized for not knowing the answers. Is always important.
Great. Christopher, one other question that came up while we were talking earlier was about, I mean, I suppose it's about continuous training and continuous development and so on, sort of that we have certainly in the UK. But would there be a certificate at the end of the module? So if you complete module whatever, or the e-learning set, does it say success? You now have a certificate. Does that work?
It does. So at the very beginning, before you even start the e-learning, you enter your name into the system, and then at the end, based off your score throughout the entire process, you will get a certificate of completion. We are quite strict in the fact that you have to complete all modules. You can't cherry pick too much about what you decide to do, because it is such a holistic component approach that if you miss a component, you're not getting the true full picture.
But nevertheless, you know, having completed it and successfully completed it, you've got something which demonstrates your understanding, at least of the principles and the processes and so on. So I'm going to probably wrap up here. I don't know if any of my panelists want to add to that from around the table, Sabai or Alex, before we wind up. We've been running for nearly an hour and a half. We're overrunning as usual.
Can I ask one thing to Christopher? Christopher, for this course, training, the assessment you done is only the MCQs. What I'm trying to ask is in your laboratory, the assessment, what kind of assessment you will be carry out to find out the competency of the new staff joining?
So specific to this e-learning, there's an entire module that is just an assessment, and it's more than MCQs. It's longer questions as well. I just didn't want to go into it today. So that's for the e-learning. For the laboratory, we set certain tasks. We look to see if we give them samples, and we look to see if they've found the ones with the issues. We've given them data. We ask them on the computer, and we ask them to see if they can give us the results. So it's more interactive in terms of, here are real data, here are real samples that look very real. Can you distinguish them? But we also continually assess them as well. So if they are weaker in particular tasks, we can then support them in the lab.
So on the combination of the MCQs and then some of the scenario testing and continual monitoring, and then the reinforced with some of the questions.
And when they go in, then they go into the lab, and when they're in the lab, they're being mentored throughout the process, so they'll watch the first few times as well. So this is just to sort of streamline the whole process as well.
Right.
Okay, great.
And, a lot of training is the most important part. Yet many people try to skip those processes very quickly because they want to use the stuff very quickly. But there is no shortcut, unfortunately.
Right, I have one question just coming in now from Dia Iskandriati. Did you do research on the effectiveness of this e-learning compared to regular training, virtual or in person? So I see what he's getting at. But is there any data, any research that's been done on how effective this is?
We haven't compiled all of this yet, but in reality, we know that we couldn't have had as many people working in our high throughput labs had we not done this. We just couldn't have trained them because we didn't have the capacity or the staff numbers to really be able to train that many people to the high standard that they are working. So we've got very busy labs full of people who've been trained that we wouldn't have that same level or number of individuals trained had we not done this.
No, and then through a combination of the continuous assessment, then you are verifying whether the e-learning has been effective through on-the-job monitoring. I guess that would be the way. Okay,
but it's a good point. We would like to follow that up.
Yeah, thank you.